Start. May you know in the crowd how many nephros by show of hands? Thank you. And pathologist? Thank you. So we have enough number of both. So in the next few minutes, I will be discussing with you. Let me make it very clear. It's a mutual discussion, and I will present a few cases that I've seen in real life practice. So I would also invite some cases from your side so that we can uh, complete the whole spectrum of IgA. So IgA nephropathy is the most common, as you know, most common glomerular disease worldwide. And if I want to put the spectrum in one word, it's heterogeneous. So you have mild disease, moderate and severe. Let me start with a few clinical cases. Case number one, we have a 32-year-old lady who presented in 2017 with subnephrotic proteinuria of around 1.8 gram. Urine showed microhematuria and with a normal kidney function. She was normotensive. And we had a biopsy on her after 6 months of ASC inhibitors. It showed IgA with mild to moderate activity. So IgA nephropathy, this article by Dr. Heather Reish, who has done lots of research from the University of Toronto. So she has given a good review article in CJASN in 2017. And one of the most common presentations of IgA include subnephrotic proteinuria, hematuria, and with normal kidney function. So what happened to this lady? She was treated with steroids as per the POSI's protocol. The kidney function remained stable, and at the end of 6 months, proteinuria had decreased to 800 milligram. The next year in 2019, since she still had subnephrotic range of proteinuria, initiated her on mycophenolate, and currently she is in complete remission with proteinuria of less than 300 milligram with stable kidney function. Of course, the treatments in IgA is complex, and if you ask 3 physicians, they will give 3 different choice of treatment. So this case was a case of mild IgA with normal kidney function. Case number 2, we have another 40-year-old gentleman who was found to have kidney dysfunction with a creatinine of 1.8 with microhematuria and 2 gram of proteinuria. And this is yet another common presentation with kidney dysfunction, hematuria and proteinuria. So it falls under the spectrum of progressive kidney disease. So what happened to this gentleman? I treated him with steroids and cyclophosphamide followed by azathioprine as per the Bellardi's protocol. Bellardi's protocol has been tested in few patients and treatment has extended up to 7 years. So the proteinuria remitted, kidney dysfunction remained stable as expected, and in 2019, 4 years from the start of treatment, creatinine is still at around 1.7, protein around 400 milligram. So he has remained in stable remission. So the next case, similar to case number 2, 31-year-old gentleman with subnephrotic proteinuria, creatinine of around 1.6 with microhematuria. Exactly same as case number 2. Treated with steroids as per the POSI's protocol, proteinuria remitted well, creatinine remained stable. 5 years down the lane, proteinuria suddenly relapsed to 1.5 gram per day. We don't know the cause. No obvious precipitating factors. A reappearance of microhematuria, however, with stable kidney function. So IgA nephropathy, classically I have found is a very relapsing disease, very unpredictable. So I put him back on POSI's protocol and he's on the second dose of steroids, 3rd month. So natural history of IgA in seminars of nephrology, Barthox et al. Has dealt with it, and the natural history is characterized by clinical progression over time, extending, varying from a few years up to even 50 years. And the three most common adverse prognostic factors as defined in the literature are proteinuria of more than 1 gram, uncontrolled hypertension, and kidney dysfunction. IgA nephropathy is distinct from other glomerular diseases in that the prognosis becomes worse as the proteinuria goes above 1 gram, whereas in membranous and FSGS, the prognosis depends on the proteinuria if it is more than 3 gram. So even subnephrotic proteinuria, even partial remission in FSGS is very significant. However, in IgA, as soon as the proteinuria goes above 1 gram, the clinician is tens. And the 20-year-old cumulative end-stage kidney disease in IgA varies from 14 to 39%. So we have the next case, it's a slightly longer one. 50 male, background diabetes and hypertension, creatinine of around 2.2 with around 2 gram of proteinuria, no microhematuria in 2015. Kidney biopsy, IgA with crescents, managed with steroids and IV cyclophosphamide for 6 months, followed by azathioprine. Responding after 1.5 years, creatinine is still the same, around 2.3. Urine protein is at 300 milligram, no hematuria. So I stopped the azathioprine after 1.5 years in 2017. Patient remained in stable remission. After around 1.5 years, proteinuria suddenly increased to 2 gram. A repeat kidney biopsy was advised. He had gone home, was lost to follow up for the next 6 months when he presented back in April 2019 with serum creatinine of 3.5 gram and with 3 gram of proteinuria. Now we had a kidney biopsy on him, obviously showed IgA. Acute tubular injury, see the percentage of IFTA, it was only 20%. So we are speaking about a disease of 4 years, creatinine of around 2.2 at start, 17% crescents. He was treated with corticosteroids and IV cyclophosphamide as per the Rocatello protocol. 2 months IV cyclophosphamide for 2 months followed by AZA. Kidney function improved, proteinuria showed signs of improvement. That was in April. 2 months down the line, proteinuria suddenly increased to 6 gram, creatinine at 5 gram milligram per dl. A repeat kidney biopsy is advised. At this time, actually, the patient was lost to follow up because of the insurance related issues. So we couldn't do a rebiopsy. Actually, he had gone home for further treatment. So this case reflects the unpredictability of IgA. And so what to do? Nobody knows. The treatment immunosuppressive therapy in IgA, we have lots of trials, and no trial has found, in no RCTs have been found to show a definite benefit of one immunosuppressive therapy. So abrupt deterioration can happen in a stable disease. The next case, 30-year-old male, presenting with generalized edema, microhematuria and 4 gram of protein. A patient with IgA whom the clinicians would like to see with nephrotic syndrome, kidney biopsy showing minimal change, immunofluorescence, mesangial IgA. So IgA nephropathy with minimal change is one of the rare manifestations, good one to see from the clinician's perspective. Steroid responsive, we have an answer of what's going on, maybe steroid dependent, and it's a diffuse podocytopathy which causes the protein leak. J. Radhakrishnan et al. Have described the IgA nephropathy with minimal change and come to the conclusion that it is a dual nephropathy, dual glomerulopathy. So mesangial IgA is separate from podocytopathy. IgA nephropathy can also produce nephrotic syndrome due to proliferative disease, but EM will not show a diffuse podocytopathy. And he responded well to treatment. Now here this gentleman, 45-year-old male, who had a serum creatinine of 3 mg per deciliter on stable outpatient follow-up for a CKD. He had a kidney biopsy around 10 years ago which showed IgA. Suddenly went on to get acute scleritis. Ophthalmologist ordered C-ANCA which was positive, rising creatinine, microhematuria. We couldn't do a biopsy because the kidneys were smallish. ANCA-associated crescentic nephritis has been found to be associated with mesangial IgA. There's an overlap syndrome where the prognosis gets worse. And if treated early, will have a good prognosis. If treated early, has a good chance of responding. In our case, actually, the disease was chronic, kidneys were smallish, and as expected, the patient went on to end stage. So other presentations of IgA, classical ones, macrohematuria, thin pharyngitic as described in the literature, often found in young people, 10 to 15% incidence. Then the IgA nephropathy presents in 10 to 15% as macrohematuria. The prognosis appears to be excellent, but in the long term, they can have proteinuria. So they need to be followed up on a long-term basis. The long-term outcome of IgA nephropathy with recurrent macroscopic hematuria has been studied and found to have better prognosis compared with isolated microhematuria, intermittent and isolated microhematuria, and no microhematuria. And then there is this clinical scenario of macrohematuria associated AKI. Patients can have macrohematuria, acute renal failure, and responding, spontaneous response. So the tubules can be blocked with the red cells, and the heme can damage the tubular membranes. This has been described in the CJASN. However, the prognosis has been in textbooks it is said to be excellent, but recently of late it has been mentioned that up to 25% may not completely recover the kidney function after AKI associated with macrohematuria. So isolated microhematuria is another scenario where the differential diagnosis include thin basement membrane and Alports, and a young person walks into the clinic. So these guys need to be followed up because they can develop proteinuria and progressive kidney disease in the long term. Other rare presentations, any patient with accelerated hypertension, IgA can be one of the causes. Increased renal echoes and ultrasound can be a presentation. So case number 7, we have this 45-year-old gentleman, post-renal transplant, spousal donor, native kidney disease was unknown. Started having intermittent microhematuria in 2017, no proteinuria, hypertension of course, normal kidney function. So we are thinking about bladder causes, kidney causes. Renal artery Doppler was normal. Had 2.5 gram of proteinuria in 2018. Transplant kidney biopsy showed IgA. We were in a fix in this patient because he had a cyst in his native kidney, which was a Bosniak 3, which were to be removed. So the immunosuppression had to be tailored. Now we don't know what type of immunosuppression to try. Probably we'll give him some steroids. The CNA has been lowered. So talking about the post-transplant recurrence of primary GN, IgA is one of the most common diseases which occurs post-transplant. Histopathologically, it is said to be 100%. Clinically, around 9 to 60%, and on an average 3 years post-transplantation. More in younger patients. For the good part of it is the graft loss is said to be less than 5%. Case number 8, 40-year-old man walks into the clinic for a routine donor workup. His brother has an unexplained kidney disease. He was surprised when he was found to have microhematuria and proteinuria of 1.4 gram, normal kidney function. So this guy is excluded as a donor. So familial IgA nephropathy has been well described, and it is said that it is an autosomal dominant pattern with variable penetrance. So it has implications on related donor transplantation. Now there is this 35-year-old gentleman who presented with purpuric rash over the extended surface of the hands, an obvious diagnosis. Proteinuria subnephrotic again, microhematuria, creatinine of around 2 milligram. Diagnosis Hinosh only in purpura with systemic vasculitis, and biopsy was again IgA. So we should not leave out the secondary IgA nephropathy. I had a patient with celiac disease and Crohn's disease combined who presented with isolated macrohematuria, normal kidney function. Then ulcerative colitis and Crohn's is yet another cause. And in this particular group of people, the activity of ulcerative colitis may correlate to the proteinuria. So if they have a stable disease, as soon as they have an exacerbation of the ulcerative colitis, the proteinuria increases. And rheumatoid arthritis and cirrhosis are other causes. So before I close, I want to take the opinion of the crowd. I had a patient, 40-year-old lady, who presented with macrohematuria all the time. She has coffee brown urine all the time, normal kidney function, 800 milligram of proteinuria. How many of you would biopsy her? Just a show of hands, please. How many would in biopsy? 800 milligram. It was a macrohematuria. Macrohematuria, normal kidney function 800 milligram proteinuria. So most of the crowd will not biopsy, right? So in this case, would you do or no? Anyway, I went ahead with the biopsy. So I went ahead with the biopsy. So how many would you go for IgA as the diagnosis? A show of hands, please. Yeah, but how much percentage would you attribute? Would you would you go for IgA as the biopsy report? Anyway, the patient had a turbulent course post biopsy, had significant bleed, drop in hemoglobin, so we had to transfuse. But the biopsy report came as normal. So what were we biopsying? Always someone. Okay. So this lady had macrohematuria and the biopsy was normal, including the EM. No, she bled because of the post biopsy complication. Hematology was okay, normal actually. Coags were normal. No, no, I'm just presenting one case. It was a macrohematuria. I'm yet to see a loin pain hematuria. Anyway, this lady has an interest. Sorry. Urology cystoscopy was negative and CT was negative. That's a good question. That's a very good question. Her maternal uncle has kidney disease on dialysis. So we are planning to do an Alport's genetics. Alport's immunostain was negative. So some other cases you really, it's an isolated one case, we cannot draw any conclusions. So before I close, let us put the take home messages. It's the most common glomerular disease worldwide, heterogeneous, unpredictable, progressive disease with or without relapses, smoldering and patchy on the light microscopy. Most common presentations, asymptomatic hematuria and proteinuria, progressive kidney disease. Classical manifestations include recurrent macrohematuria and synpharyngitic hematuria. Overlap syndromes with ANCA and minimal change. Post-transplant recurrence. Familial pattern. Not to forget the IgA in post-infectious GN, especially associated with staphylococcal infection, diabetes, HIV. In bevacizumab therapy, you can get IgA deposits. Thank you. This is my hospital, NMC Royal in Abu Dhabi, the biggest private sector hospital. We may start transplants in the. Thank you very much for the patient listening.